Good evening and welcome to this webinar on bringing the hospital to the patient, organised by the European Association of Urology Nurses. I'm happy to say that we have over 80 registrations, which is fantastic this evening. My name is Chatterton. I am a bladder cancer advanced nurse practitioner working at Guy's Hospital in London, and I'm on the EAUN Special Interest Group for bladder cancer. And I also have my very good colleague, friend here with me tonight as well, Bente, who is also a CNS and assistant professor at Aarhus University Hospital. Before we begin, I would like to extend a big thank you to the EAUN for putting together this event. Without their support behind the scenes, none of this would have been possible. And secondly, I'd like to express thanks to Medac Pharma for their generous sponsorship. During this webinar, please feel free to ask any questions through the questions portal, and at the end we will have some time for discussion to hopefully address some of these. This webinar is also accredited with one continuing nurse education point, which will be awarded after completing the post-webinar questionnaire. So without further ado, I would like to introduce Masood Moghul, who is a urologist currently doing full-time research based at the Royal Marsden Hospital and Institute of Cancer Research in London. And he's leading on the Man-Van project. And we're all eagerly looking forward to gaining an insight into your experiences and diagnosing patients in the community. So please, over to you, Masood.
Thank you. Thanks. Thanks for the intro. I'm just a urologist doing a PhD at the Institute of Cancer Research and the Royal Marsden, which sometimes can feel like a bit of a hotel, but it's a nice place to work. I don't have any real disclosures, although I've given a couple of talks for Bayer, also on the Man-Van. So this is the Man-Van. These are a few pictures of the Man-Van. This is something I've been doing for about 3 years now. So this is basically been my life for the last 3 years. Very interesting project, multifaceted. The PI of this project is Nick James. So he's also PI for Stampede, and also just recently led the Lancet Commission on Prostate Cancer as well. So there's lots of tie-ins with Man, and I appreciate that this a lot of the topics are more focused on bladder cancer. I'll be talking quite a bit on prostate, but we can explore some of the parallels with bladder. I do have a clinical interest in bladder cancer as well, so it's not to push that away at all. So a little bit about health inequalities, because that kind of sets the scene for why we're doing this project. We know that deprivation is a determinant of life expectancy. And in the UK, what that means is if you're in the most deprived decile versus the least deprived decile, you've got about a 9-year difference in overall life expectancy. We also know that ethnicity can be linked with deprivation. That's true in the UK. It may be true in other countries in Europe as well. But what that means is that if you're from a certain ethnic minority, you're more likely to be in a deprived group. So that obviously compounds the problem. We also know that cancer mortality increases with deprivation. This is multifactorial. There are lots of reasons to this, including reduced awareness of symptoms, increased barriers to accessing healthcare. So there's lots of reasons why that might be. And we know that screening alone does not solve this problem. This is particularly relevant because obviously there is no screening program. Well, there hasn't been a screening program for prostate cancer, but there is for other cancers such as breast cancer and ovarian cancer, breast cancer and gynecological cancers as well. So, but the problem with that is that screening uptake falls as deprivation increases. So that's not necessarily a complete solution. And even with screening programs, you do need to look at how you can increase participation. So this slide shows some information about prostate cancer. This is UK-based data. So prostate cancer is the most common male cancer in the UK. It's the second most common male cancer worldwide. In the UK, we have around 50,000 cases per year, 12,000 deaths, similar stats in most of Western Europe. Survival is linked to the stage at diagnosis. So if you're diagnosed stage 1, stage 2, your 5-year and even 10-year survival is pretty good. It'll be above 95%. If you are diagnosed at stage 4, that starts to drop off. So stage 4, 5-year survival is around 60%, and 10 years it's only 20%. So this is a cancer, like most cancers, that you want to diagnose early, you want to pick it up early. And crucially, about 24% of new cases in the UK are diagnosed at stage 4. So for an advanced, so-called advanced nation, that's quite high, and really shouldn't be the case. So how does deprivation impact cancer mortality? So you're more likely to die from cancer if you're from a deprived group, and you're more likely to present with metastatic disease. And it's probably no surprise that those two things are linked, and that delayed diagnosis is a key cause of the increase in mortality rate. And there are similar features found across all cancer groups. So how can we improve these outcomes, particularly for the patients that are the worst affected? I'll be talking specifically about men, because this project is primarily based on prostate cancer. So we developed the Man Van project, which is a mobile outreach clinic. It's a big van that is designed to target these high-risk groups. These heat maps that you can see show areas in London, this is North and South West London, that have higher proportions of Black men and increased deprivation. So you can see the darker spots are the areas where you've got more deprivation and an increased proportion of men from Black communities. So these are the sorts of areas that we wanted to focus our project in. A little bit about the timeline of the project. So it is, just to give a little background, this started in Birmingham when Nick was working there. He was in Birmingham for about 20 years as a consultant. And one of his patients, the man on the right of the picture, Johnny, who presented to him in that same way, which I think lots of people will have seen, which is having urinary retention, pitching up to the emergency department, having a catheter put in, being seen in clinic a few weeks later and being told that he's got metastatic prostate cancer. And they got together and decided that they should do something about this, came up with the project, raised money. Unfortunately, Nick couldn't start the project in Birmingham, and then he moved to the Royal Marsden in London, and that's where we took things on from. So our model, so we target these high-risk groups based on this population data that you've seen. We used lots of different communication methods. Mainly, we used primary care teams, so GPs, and working with them, getting them to send out text messages on our behalf, but also working with other community stakeholders, community leaders, church pastors, whoever we thought could really help and increase participation, but not just get numbers in, but get numbers of men in from the right groups. Using our model, we had appointments booked for about 20 men per day, which resulted in seeing about 100 men per week. And we would keep the van in a particular area for around 6 to 8 weeks, often a bit longer, just to get through as many patients as we could in a particular area before moving on. To try and increase the overall value of the service, we also do a few other tests, including a blood pressure, diabetes, BMI check, because we know that with targeting these sorts of men from these high-risk groups, you're more likely to find these other health conditions as well. So if we can find other health conditions, hopefully that makes sense, that we can increase the value that is gained from the project. So these are some results from our pilot, our initial pilot. So this was in 2022. And some key results here. So around 30% of the men that we saw were Black. This is off a background from South London, Croydon, where the background population was probably around 15%. We saw about 600 men and diagnosed 15 prostate cancers, and 9 of which were clinically significant. There was only 1 cancer that we found, which was metastatic at presentation, which is what we want. We ideally do not want to be finding metastatic disease. We want to diagnose it early. And these rates are a lot higher than what you'll find in most of the screening studies. Interestingly, these are small numbers, but we had a much higher rate of prostate cancer detection from Black men, again, perhaps higher than you would expect. And quite a high rate of other conditions as well. So diabetes, blood pressure, sort of re-emphasizing that if you are getting these sorts of men into a healthcare service, it makes sense not just to do one thing and to do more than one thing. And this perhaps fits in quite nicely to a role as a urologist, which can be a sort of general men's health review, which ties in with other things like erectile dysfunction as well. And by tackling all of these problems, you're actually sort of you're actually able to increase the value of the service. After 2022, we had our second phase. This is only 6-month data from that second phase. This is from all of 2023. We did end up seeing 3,400 men in the whole year, but I've only got the 6-month data at the moment. So that's 1,400 men that were booked in. We ended up seeing 1,200. Our ethnicity rate dropped, but that's sort of linked to having a much bigger service where you're seeing a lot more people, but it's still very much higher than the background, and the background population where this phase of the project had a much lower rate of Black men. We did about 1,000 PSA tests and about half that number of HbA1c tests for diabetes, again picking up significant numbers of both. We did find 1 bladder cancer. I didn't mention, but in the earlier phase, we also found 1 bladder cancer, which was an incidental finding based off a prostate MRI, which picked up a lesion in the bladder. This bladder cancer was actually diagnosed from a hematuria pathway. How a pathway in the UK is very much a pre-biopsy MRI followed by a transperineal prostate biopsy. I haven't mentioned yet, but this entire pathway is basically nurse-led from start to finish. The van is staffed by urology clinical nurse specialists, and our diagnostic pathway at the Marsden is also run almost exclusively by urology advanced nurse practitioners and nurse consultants. So I think that's something that's really important in terms of thinking of ways for expanding this service in the future. So from the 6-month data, we had 100 referrals for elevated PSAs. Most of them ended up with MRI scans, and we ended up finding about 1/3 of them with prostate cancer. Most of that prostate cancer was clinically significant. So we are saying clinically significant as being Gleason 3+4, more than 5% pattern 4. The overall diagnostic rate around 3%, so pretty similar and being maintained from what we found in the earlier phase of the project. So moving from sort of the 2 phases of the project, we've tried to increase our service efficiency. How did we do that? I haven't gone into detail in this talk, but utilizing online registration forms, trying to get all of the information we can on these patients before they actually attend, including IPSS and IIEF5 questionnaires. So we've got a streamlined service, which hopefully will increase the throughput and the cost effectiveness. We've tried to maintain our ethnic minority participation, which I think is important, particularly with prostate cancer, which of course affects Black men more. Got a really high diagnostic rate of clinically significant disease, which suggests that by targeting these high-risk men, we're able to push that case mix towards the higher risk disease, which again has been a big criticism of previous screening studies that you're finding, Gleason 6, which is usually not treated at the moment. And we're doing further work, so we're trying to find out why a lot of this happened and how we can improve the service further. Thank you. That's the end of my talk.
Thank you, Masood, for the opportunity to share your insights on the diagnostic patients in the community. Really interesting and certainly a very innovative outreach programme. And I'm excited to discuss that afterwards and then putting the spin on how we could perhaps utilise that for our bladder cancer patients with your experience. So that would be great. As I mentioned, please leave your questions to the end, pop them into the Q&A section in the bottom of your Zoom, please, and we'll be able to answer those at the end. Now I'm going to introduce Laura Noble, who is a uro-oncology specialist nurse working in Newcastle, and she's going to talk on community intravesical therapy. We know that intravesical therapy obviously plays a pivotal role in the management of non-muscle invasive disease, and we have the opportunity to delve into this further with Laura, looking at how they've set up a robust service in their community. Thank you, Laura.
Thank you, Catherine. As Catherine said, my name's Laura Noble. I'm a bladder cancer nurse specialist at the Freeman Hospital in Newcastle, and we're a tertiary referral centre. Sorry, I've got no disclosures, by the way. Tertiary referral centre for the northeast of England, and we use a hub and spoke model. So at the Freeman, we're the hub, and we have spokes locally, usually within about a 10-mile radius. Tonight, as Catherine said, I'm going to share with you our community intravesical service, where we offer intravesical chemotherapy and immunotherapy to patients in their own home. We've been offering the service now for over 20 years. It was first set up in around 2001. And we hope that by sharing our service and our experience, that we can inspire other people to offer this treatment. So what do we offer in Newcastle? We offer treatment in the hospital and the home. So in Newcastle and the surrounding areas, which are Gateshead and north of the river. We have 2 clinical nurse specialists whose primary role is to administer intravesical treatment. And between those 2 nurses, we offer 5 treatment days or sessions per week. So this is between Monday and Wednesday. We have a community session all day on a Monday, 2 sessions on a Tuesday, and then 1 community and 1 hospital-based treatment on a Wednesday. If our demand exceeds capacity, which does sometimes happen with the peaks and troughs of intravesical treatment, we can use a Thursday, but we would never in Newcastle offer intravesical treatment for bladder cancer on a Friday, given any complications over the weekend. So as I mentioned, 4 of our sessions are community-based. So the high majority of our work is done out in the community. But we do have 1 session in the urology treatment suite within the hospital, just so that we can offer the choice to the patient. Undoubtedly, this is a quality service over a quantity service. We could definitely see more patients within the hospital, but this would mean that some of our patients wouldn't be able to access our treatment. And overall, we find that it is just much more convenient for the patients to have treatment at home. So how does community treatment work? We get asked it again and again, how do you manage this? And overall, it is very, very similar to a district nursing concept. It aims to bring treatment or care to patients in their own home, that wouldn't be able to access it otherwise. We do travel in our own cars and we have the correct insurance, and all travel expenses are reimbursed by the trust. We have to submit forms on a monthly basis, and that's paid into our wages. And at their diagnosis appointment or their pre-treatment appointment, patients are offered an appointment based in the hospital or the home. They make that decision as long as they are within our treatment area. And appointments are all allocated on a need or route basis. So we do try and do it by route. However, we like to accommodate patients who still work, patients with young children. We just like to work around the patients as best we can. We are very flexible. So each appointment is allocated 1 hour apart. Geographically, that works well. It gives time to administer the treatment, travel between patients. It allows for a bit of traffic, because patients do become quite dependent on you. We end up with patients, you're 5-10 minutes late and they're ringing to see where you are. So we like to give plenty of time in between. It seems to work well for us. The treatment, the unreconstituted treatment, is stored securely in the boot of the car. And the box that we carry it in is marked as cytotoxic. It has advice on what to do in an emergency situation. So if we had a car accident, it clearly states what an emergency service man or woman would need to do. They would need to contact the cytotoxic pharmacist, and someone would advise on how to handle that properly. But like I say, it is stored in a big box and all the treatment is reconstituted. The BCG that we use as well, which is normally stored at fridge temperature, it can safely be transported at room temperature for 12 hours, and that's without affecting its efficacy in any way. At each appointment, the patient's symptoms are assessed to ensure that treatment's not contraindicated, such as hematuria, significant urinary symptoms. The first visit is always slightly longer. We'll go over the treatment again, the treatment schedule, side effects, and complete the consent process. The treatment is then administered, and this is usually done in the patient's bedroom. Although, it would be arguable to say that we do this in some strange areas, conservatories, family and friends' houses in some cases. The patient's records, we keep a set of patient records in their house, just in case, any other district nurses needed to see them. But the records are completed after the treatment's been administered. We take the cytotoxic waste for disposal. All of the non-cytotoxic waste is disposed of by the patient. And then the patient will void the treatment once the nurse has left, after the dwell time of 1 to 2 hours, depending on the treatment. And the patient is always given the contact details for the nurse in case of any adverse events, unable to void treatment, anything that the patient is concerned about, any significant side effects, they're able to contact the nursing team. They each have a mobile phone for working hours. They're easily contactable, and out of hours, they're given the number for our emergency assessment suite. So what are the benefits of home treatment? We do it overall to benefit the patient, but it does give us as nurses a lot of job satisfaction. You build really, really good relationships with the patients. You get to see, the family photos on the wall. It's just a really nice relationship to build with a patient. They like to feed us as well, which is always good. Overall, though, the treatment is accessible and inclusive to most of our patients, with the exception of those that live outside of our treatment area. We do get patients that do live too far away, and it's just not sustainable to deliver their treatment, so they come into the hospital. We are able to treat more patients as well, so we offer treatment to patients who otherwise wouldn't be able to access it, who wouldn't be able to come into the hospital. And that could be mobility or health issues, but also financial issues. So the current financial state of the UK makes the thought of paying for taxis or public transport, or even just petrol and parking to the hospital once a week for 6 weeks, it's really difficult. So we like to take that worry away. As I've mentioned, we've been doing this for over 20 years, so it's proven to be a safe and effective way to do things. And above everything, it offers the patient a choice. Like say, we continue to have the hospital treatment, and that's for patients who want to come into the hospital because they want to separate cancer treatment and home life. And I think, you know, that's very understandable, especially for younger patients and those with children. We get patients that haven't told their families about the diagnosis and don't want to tell them about the treatment. So they're able to come here. They don't have nurses going to the house. Equally, it works the other way. Sometimes they don't have to explain where they're disappearing to once a week for 6 weeks when we pop to their house. And overall, we really do have very positive feedback from the patients. It's always a well-evaluated service, especially for offering that quality of treatment and care. I once asked one of my patients, how does having home treatment affect you? And her answer was, it doesn't. She said, but what would affect me was traveling to the hospital every week. People would start to wonder where I was going. So it just shows that we pop into her house, administer the treatment, we leave, and she just carries on with the rest of her week. So we disrupt her week as minimally as possible. It's pandemic friendly, so having this community service massively benefited us in the COVID-19 pandemic, where all hospital treatment was converted to home treatment to keep patients out of hospital. And it's also sustainable and efficient. On this map, this is our geographical area. So Newcastle is the little blue dot in the middle. And we go both north and south. We cover approximately a 10-mile radius, but we do go further south than we do north because we cover treatment for one of our our spoke hospitals that don't offer any intravesical service. So we do all of theirs on a community basis. And then this picture, the blue line is our divide. So we have a nurse who looks after the south and a nurse who looks after the north of Tyne. So this is our Tyne River. Red and blue arrows, they indicate each patient's journey to and from the hospital. And granted, we do usually see more than 5 patients in a day, so this would be more. But if we think about the cost of each one of those journeys financially with parking, public transport, but the patient's time as well, and the fact that those return journeys, those patients usually have treatment in situ. And then this is the equivalent of us, our nurses leaving the hospital, traveling on one single, which means that the patients as well are staying in their own house. So the treatment is minimal. Where they can void the treatment. So if they're on public transport and they had an episode of incontinence, there's no risk of the treatment being voided elsewhere. And just before I move on to that slide, so between those journeys, the ones with the arrows of the patients coming to and from, that's equivalent to 193 miles for those 5 patients, versus the nurse just doing one single trip is 46.5 miles, so a significant reduction. So if we move on and look at the sustainability of this, there is a waste reduction. So cytotoxic waste, only bringing that back to the hospital has massively reduced the cost and the waste for the trust. That wasn't something that we did before the pandemic, but it is now, and definitely has made our practice better. The transport reduction, so significantly reducing the carbon footprint by effective route planning. And then what we also use is closed systems. So we don't reconstitute the treatment. If it's contraindicated that day or it's omitted for any reason, it's not wasted. So it's more sustainable in that way. So this is me and the team, me in the middle, there's Sarah and Emma, and we're the team, the bladder team at the Freeman Hospital. And if you have any questions, we'd love to hear from you.
Thank you so much, Laura. This was an excellent talk and very interesting for, I think, 50% of the European clinics performing intravesical instillation therapy, because this is really something which we don't know much about, this home therapy treatment you talk about. But the next speaker, Lene Munk, we don't offer home service installation in Scandinavian, but we do offer another home-based service which Lene will introduce us to. And Lene is a PhD student. She's a medical doctor, but she's also a PhD student at Aarhus University Hospital in Denmark. So Lene, you will present patient self-reporting side effects and at home with it's a novel system. So please go ahead from here, Lene.
Thank you very much for letting me talk about this very exciting topic, and I think it falls beautifully in line with what we just heard. So I have nothing to disclose. As Spencer just mentioned, I am a medical doctor, and I'm also a biomedical designer with focus on innovation in the healthcare sector. And currently I'm a PhD student. I'm conducting a bladder cancer study at the Department of Biology in Aarhus. So what I'm going to talk about firstly is patient-reported outcome measures, or PROM, because it's important to have the patient in the center, because we know it improves satisfaction with care, but it is also proven to increase survival amongst cancer patients. So earlier on, and still today, we collect these PROM data from our patients by giving them paper and pen diaries, or we also ask them when they come to the clinic or outpatient clinic. And sometimes when they're asked directly by healthcare professionals, maybe nurses or project nurses or doctors, I know at least that doctors might tend to underestimate or underreport what symptoms or side effects that the patient actually experience. But there are new ways and new platforms, electronic platforms, to gather this information from the patients. And that is web pages where they can just type in what they know and what we want them to answer to. And they can also do it in tablets. At least in Denmark, we sometimes do it while they are waiting for the next appointment or afterwards. And we're also starting to use smartphones to collect this EPROM. And this gives us the opportunity to collect this data with an ecological momentary assessment. That is, when they do this at their home, it's their real-time data that we're collecting. They are in the real-life circumstances, not being somewhere away. They can be influenced by the pace of the patients around them or feeling pressure to answer something. They can just do it in their own home when they want to, and they can maybe give a more correct answer to the side effects or symptoms that they actually experience. And what it also does is that it minimizes the risk of recall bias. They don't have to think back a week or 2 weeks or even months sometimes. So with that in mind, I would just give you a brief introduction to the PhD study that I'm conducting at the moment, because it is how we collected the data from these patients. So I am the PI for the North Rectal Time study, where we include patients that are treated with BCG as we just heard, it could also be at the patient's own home, but in Denmark, we do it at the hospital. We use a dwell time of 2 hours. And in Denmark, we give the patients 15 installations total within a 1 year period. I've tried to display it in the bottom of the slide. But the problem with BCG is that up to 70% of the patients actually experience side effects. So that is what we wanted to do something about in this study. So instead of patients having a dwell time of 2 hours, we actually reduced the dwell time to 1 hour or 30 minutes if they have a certain degree of side effects. So what we did in order to monitor the side effects that the patient experienced was that we each day during the installation week sent out a questionnaire, and we did that by using text messages. So in total, a patient would receive up to or a minimum of 90 text messages. But if they didn't answer the initial one, we would send a reminder 2 hours and 4 hours later. And furthermore, we also sent quality of life questionnaires 4 times during the year. They were a bit longer, but it still it worked anyway. So what we did was when we included the patient in the study, we asked for their phone number. And in the database, we had a predefined email that was linked with the patient phone number. So when we activated this email, it was sent to an external company that then converted this email to a text message. So when the patient received the text message, they just clicked on the link and then they got right into the questionnaire. And when they have filled it in and submitted it, all the data returned directly into our database again. And this is just what it looked like inside the RECAP database. So I could see all the answers. And on the basis of that, I built an algorithm in the RECAP, and then I could decide what to do for the next treatment. And I knew exactly for each day how the patient had felt. And this is what the algorithm showed me, whether or not we should stop treatment, reduce, or postpone the treatment. So this is some of the data that I've gathered so far. What you can see is that we actually also use this technique by sending out text messages before they even started their BCG installations. So let me just explain this briefly. What you see here is all the patients with a normal frequency, all the patients with a moderately affected frequency, and all the patients with a severe affected frequency. And as you can see here, week 1 was when they received the first installations. And actually a lot of patients moved to a higher degree of side effects. But something that we noticed when we monitored these patients so closely was that the side effects that they experienced or symptoms that they had before they started actually persisted or in some way progressed. So being able to do this kind of closely monitoring of side effects actually gave us a lot of information on how to help these patients moving forward through their installations. And I can tell my patients, if you have these side effects or symptoms, when you start, then you can expect this moving on. So at the moment, we have sent out more than 13,000 text messages to our participants, and we reached a response rate overall of 95%. For the daily questionnaires, which is of course the majority of the questions or text message that we sent, we reached a response rate of 96%. And what is interesting is that our quality of life questionnaires also have a really high response rate. And one could argue that the high response rate for the daily questionnaires was because they were more motivated, because it had a consequence for the treatment for the next installation. But for the quality of life, it was simply nice that they knew the technique and they were willing to try it out and answering it on the telephone. The participants are on average 70 years, but we have 1 or 2 patients that is 87. And I could also see in the RECAP database that it took the participants a maximum of 3 minutes to answer the text message or answer the questionnaire. But in average, I would say it takes them 1 to 2 minutes. And when I asked them how they experienced this way of collecting EPROM, they actually like it a lot. It is accessible, it's easy for them to do. And the more that they answer this in this way, the faster they also get at answering it. But it's also widely used outside of urology. There are a lot of different studies that have been done for weight loss, alcohol consumption, diabetes, and in Denmark we use a lot of text messages to send reminders of appointments to at the hospital for the patients, and it has proven to be feasible to do this. So I see this use of text messages to be and to have a big potential, because it's faster for the patient to type in how they have felt. It's easy for them to use. Actually, I conducted this study across Denmark, Sweden, and Iceland, and I have used the same way of collecting all this data in all 3 countries. And everybody has experienced the same benefits as we did. And also the fact that we don't have to handle all of this data manually is time saving for us, because the data just go directly back into the database. And I also think it's extremely important that the data that we get is when the patient feels the safest, because I think that is when we get the most correct answers. They don't feel pressured. They can give us an idea of how they actually feel at the moment they are experiencing side effects or symptoms. And it's actually also cheaper. It's extremely cheap to send a text message. Everybody has a telephone. So I think that it's a new way, and I think it's a way to embrace that we are moving forward and use all the things and tools we have available at the moment to just increase our patients' satisfaction with care. So thank you very much for your attention. And if you want to try out the questionnaire, you can just scan the QR code, and then you can try out to fill in the questionnaire for yourself. Thank you.
Thank you so much, Lene. It's quite exciting that you have that many data. You said more than 30,000?
13,000, yes.
Yeah. It's going to be interesting to follow also the quality of life data, because that's usually the tricky ones. But But now we are at the end of these 3 excellent presentations, and I will ask all the speakers to log on again. And now we have this final session where everybody can ask this expert panel whatever they want to. So almost. But I hope the audience will ask questions, and you can use the Q&A block. I hope so, but can we see any questions here so far?
Yeah, there are 5 questions.
Yeah,
I think
yeah,
they're in the Q&A. They've moved them. I can't see them myself, but I remember one for Laura. There was a question on whether you test the urine prior to giving the intracycle therapy in the community.
Oh, I have
Laura,
So,
are you there? Yeah.
yes, no, we don't. We did, and we got too many complications for it. We have a bladder meeting once a week with our consultant, bladder specific consultants, and we agreed that we do not test urine unless a patient is symptomatic prior to installation, and that's across the board in the hospital as well.
Now I see here there's also a question for Moghul. How did it work with funding the prostate van initiative?
So we had funding from NHS England. There are, I mean, I think what's quite nice about that kind of model is that it's very easy for a charity to promote it. They just, it's because it's a physical van, you can just put your stickers on the side. So any private organization or charity, we did have a lot of interest, but actually our funding was from NHS England because it was part of a pilot program.
Another question is from, and forgive me if I don't pronounce it correctly, Khalid Kaur. Great service, Lara. How many patients do you have each day at home? That was the first question.
So the most we tend to treat in a day is about 8, but that is pushing our limits really to not have to rush.
Yeah, all right.
And
Her next
Sorry.
question is, what banding of nursing is the team delivering this?
Band 6 nurses.
Okay.
Band 6 nurse specialists. So only our nurse specialists administer the treatment.
Okay. And how long are they under, what do you say, sort of education? When do you leave them? Or when do you say it's okay, you can go?
We tend to, there's no set time, but they spend time in the hospital, time shadowing, a colleague in the community, but it's usually 3 or 4 weeks to build that confidence to then go out in the community. It's a completely new environment for most people. So usually after about 3 or 4 weeks, people feel more confident to go out and do it themselves.
Okay. And her last question, and are you able to share your SOPs and governance policy with the audience?
Yeah, absolutely. We're happy to share any of our information, especially to encourage it elsewhere.
Okay. And there's also a question, I suppose, for you from the new EAUN chair, Madam President, Corinne Tillier. Thank you, Lara, for your very interesting lecture. I was wondering if, in cases of suspected UTI, the nurse can collect a urine sample for culture and decide to postpone the bladder installation.
Yeah, absolutely. Any patients that are symptomatic of a urine infection, the nurse still visits, discusses the symptoms, gets a urine sample. Once it's been, and we always send that off for culture. If there's no infection, we'll just reschedule the appointment, say, example, on a Thursday. But yeah, a patient that's symptomatic, we always send a urine for culture just to make sure.
Okay, thank you so much. And Rebecca Martin is asking you, I guess, Lene, how do you see smartphone EPROMs being integrated into standard of care in the future?
Yeah, it's a good question. What we know and how we have gone about it in my study is that it's going back and forth through a safe database. But at our hospital, at the oncology department, they have a program that's integrated into our patient records. And there they send it out by email. So I think that we are not far from being able to collect these kind of data and integrate it into our own patient reports. But I still think it's kind of new. So we need more data in order to persuade that there is no problem by doing it in this way.
And there's another one for you as well, Lene, here. What impact has the implementation of this system on the patient engagement and empowerment in managing or improve their self-care?
I think it has a huge benefit for the patients because they know that I know how they feel. So I actually also think it's time saving because before they come for the installation, we already know how they are feeling, whether or not they should actually have the installation, so they don't have to drive all the way to the hospital in order to know being answered that they have to go back home because they're not able to receive treatment anyway. And actually, we're also able to, within the questionnaire, there's a question whether or not they are suspected of a UTI. So we can start treatment earlier so that they don't have to postpone their treatment. So in that way, I think we are optimizing both their time and our time in this way. And I know that they like to be observed or have an easier way, so we know where they are, how they're feeling.
So we're actually only waiting for a cost effectiveness investigation, or even a cost benefit.
Yeah, we should definitely look into that.
Yes, thank you. All right, any other questions from the floor? Please move forward.
Yeah, I can see another one for Laura, asking about products and remaining stable outside of the pharmacy, specifically about immunotherapy. Do you make this up in the community, or are you taking it in your cytotoxic box already made?
So we use a Medac close system for ours. So the vial box is kept in our kind of cytotoxic box, which is a cool box. We do have cool packs in there, but we have been assured, we've got all the information to say that that is stable for 12 hours out at room temperature, and it doesn't affect its efficacy. It's very rare that we do bring treatment back, but we don't draw it up until we've assessed the patient's symptoms.
And you talked about the cytotoxic disposal. Do you have a specific cytotoxic bin for each patient's home, or do you use the same one moving around in the community?
So we have a travel, it's like a travel bio bin or cytotoxic community box that again is kept in the boot of the car, and all of the waste goes into there. So we take out bags, it gets put in bags. So by the time it goes in the cytotoxic bin, it's in about 3 bags, and then it's kept in in this box, and then we dispose of that in the main cytotoxic waste at the hospital. But before that, we used to come back with bags and bags of rubbish. It was excessive.
Thanks. I've just got a question for Masood, actually. With your interest, obviously on the other side with bladder cancer, for the listeners tonight, I guess I'm interested in how you think, having been experienced within the prostate side of it, how you could see this perhaps working for the bladder cancer pathway. I'm in my head, I'm thinking disposable flexies behind a curtain, and, you know, with the men's health thing and increasing, you know, which is great for your service, looking for the diabetes and things like that. Do you think this is something that could be transformed into a sort of a hematuria van?
Yeah, it's a good question. I think what's at the moment probably the limiting factor is a diagnostic test. That's sort of quick and easy and can be done in the community. We weren't really too sure in the beginning how to test men with urinalysis, what sort of criteria to use, and ended up referring too many along a hematuria pathway that didn't have risk factors but had usually microscopic hematuria. I think in general, it is an additional benefit that if you have this sort of service, the primary focus is prostate, but then one of the questions we ask every man that comes in is have you had hematuria? So it does come up, but if once we develop better urine tests that could be used as sort of like a screening test, maybe something involving urinary circulating tumor DNA or some other kind of test, then I think it could really kick off. I think the sort of community diagnostic flexies, yeah, I mean that would be really easy to do in this kind of model, as long as you had enough numbers, and you just had enough people to do the testing on. So yeah, I mean we found one bladder cancer, but thankfully that was only from 38 referrals, so we didn't refer too many people, so we didn't have too many unnecessary investigations, which is something that we learned from the first phase when we referred a lot more and didn't really find anything. The issue with bladder cancer is that it's much less common, but it is usually a much more aggressive cancer compared to prostate. So early diagnosis is even more important. Trying to get it when it's superficial, when it's not muscle invasive, super important. But at the moment, the real limiting stuff, I think, is just having a good test. Otherwise, you're waiting for men to pitch up with hematuria.
Thank you. I'm just conscious of time because it's 7 o'clock, so we must come to an end. I just want to express my immense gratitude to all our speakers tonight. Normally I'd give a round of applause, but obviously we can't do that. But I'm personally feeling empowered from all the information that has been shared this evening, whether it's sustainability, home treatments, diagnostics in the community. It's been brilliant. Thank you again. I'd also like to thank the EAUN and Medac Pharma as well for sponsoring the webinar this evening. Please remember again to check your inboxes for questionnaires and also post-webinar evaluation, please, and also receive next week for gaining the accreditation for attending this webinar too. And you'll also be able to watch the recording on the EAUN webinar. So I wish you all a pleasant evening and thank you for joining this webinar, and your participation has been greatly appreciated. So thank you very much and have a lovely evening.